like to apologize for the shifts in the talks today. And I finally managed to put a presentation together. There are some slides that I would have liked to show you that are missing, but well, I'll do my best. It's remarkable hearing the previous talk in which depth actually science is going, studying the inflammatory process inside the lung. And this is a contrast with the little information that is accessible to the clinician at the bedside, especially talking about circulation. So we are almost blinded to what's occurring inside the lung in terms of perfusion and circulation inside the lung when we have to treat our ARDS patients. So even to answer this question, does circulation have an impact on ALI or ARDS, is difficult to answer from a clinical point of view. Of course, when it's too late, we can easily answer that when we see a lung like this, that perfusion has probably had a major role in destroying this complete lung, converting it in a mass of bloody edematous tissue. But this is too late. Giving some physiological information, which I think are important to get into the details. The pulmonary circulation has a very specific characteristics. It is a high flow system. It receives the complete cardiac output. It is a low pressure system, so it is very susceptible to hydrostatic processes and reactive to hydrostatic problems. It has a low resistance, a high compliance circuit. It has a huge endothelial surface with all these active cells being exposed to this high flow, and it has a relatively fragile blood-gas barrier with a very thin layer of 0.2 to 0.3 micrometers. Another peculiarity is the regional distribution of perfusion according to the West Zone model, in such a way that the dependent most inferior parts of the lung receive most of the blood flow, and the blood flow here is driven by the gradient between the arterial pressure and the venous pressure, whereas in this zone 2, the blood flow is driven by the difference between the arterial pressure and the alveolar pressure. Another important feature of the pulmonary vasculature is the hypoxic pulmonary vasoconstriction reflex. It's a very efficient reflex to maintain ventilation perfusion matching. It occurs in precapillary arterioles, but also 20% of the response, or the hypoxic response, occurs in the pulmonary veins. It is triggered mainly by the alveolar content of oxygen, but also, to a lesser extent, by the venous PO2. And importantly, it has very marked interspecies and inter-individual differences, which is make it very difficult to predict and to as I said, predict the response in a particular individual, especially in a state of disease. Another particularity is that the pulmonary vascular resistance is mainly influenced by the lung volume in a U-shaped form. So, going to the real problem that we have to face during mechanic ventilation, especially in acute lung injury in ARDS patients, the blood-gas barrier dilemma is that it has to be strong enough to withstand the normal stresses to which it is submitted, but it has to be thin enough to accomplish its very important function of gas exchange. But, as I said, it is strong, but whenever you apply a stress that overcomes this capability of the blood-gas barrier to bear it, we must face the pulmonary capillary stress failure. This term was introduced by West many years ago, and it refers to the damage produced to the capillary wall induced by repeated or continuous exposure to high vascular pressure or to high lung inflation volumes. And the sequence is that with this constellation, we have a high capillary transmural pressure. This results in ultrastructural damage of the cells, and grossly it ends in a high permeability pulmonary edema and frank hemorrhage of the lung areas exposed to the capillary stress. Morphologically, these spectacular images from electron microscopy are showing the breaks that are produced in the surface of the alveolar cells, putting in contact the alveolar lumen with the capillary lumen, where actually the red blood cells are protruding out and invading the alveolar space. So these are the morphologic expression of the capillary stress failure. A very easy way to understand how capillary stress failure is produced is by specific pathologies where we have stress failure in the absence of ventilation. So the common to all these processes is a increased pulmonary arterial pressure and increased pulmonary capillary pressure. We have the high altitude pulmonary edema, which is probably the most studied pathology. The not as good known neurologic pulmonary edema has also been described in athletes during strenuous exercise, that they are submitted to capillary stress with hemoptysis and recovery of red blood cells in the BAL. Also shifts in the perfusion inside the lung during pulmonary embolism processes. We can submit some parts of the lung to an excessive perfusion. As I said, common to these processes is the increase of pulmonary capillary pressure. So what are the pressures ranges we're talking about? In high altitude pulmonary edema, it's about 25 to 30 millimeters of mercury. That's what has been measured in athletes, up to 20-25 millimeters of mercury. In racehorses, remarkably high, up to 100 millimeters of mercury. But importantly, again, there's a great interspecies variability in the capillary pressures, and it is depending on the size of the animals, in such a way that larger animals tolerate higher pressures and smaller animals tolerate smaller pressures. So high altitude pulmonary edema, as I said, is a consequence of an overwhelming hypoxic pulmonary vasoconstriction response. And the characteristics of this response is that it is heterogeneous and it is not produced in the same way in the different vascular territories inside the lung. This results in an overperfusion and an overpressure in those areas that have not been submitted to vascular contraction. And this is a study done on healthy volunteers on a high altitude where all these parameters were measured. And patients susceptible to develop high altitude pulmonary edema showed a significant increase in mean pulmonary arterial pressure and a significant increase in pulmonary capillary pressure. More interestingly, the patients susceptible to develop high altitude pulmonary edema seem to have a susceptibility to an endothelial dysfunction. In this study, they took the patients to develop the high altitude pulmonary edema and submitted them to ventilation or to breathing low concentrations of oxygen, creating an hypoxic state. And then they measured the capability of the endothelium-related vasodilatory response that was triggered by infusion of acetylcholine. So patients susceptible to development of high-altitude pulmonary edema showed a alteration in this vasodilation response measured by the 4M blood flow, which was a systemic vessel, meaning that this is an endothelial problem. So there's an endothelial dysfunction, and there is no reason why not to extrapolate this to patients during ARDS or acute lung injury submitted to hypoxic areas inside the lung. Another interesting fact about hypoxic pulmonary vasoconstriction is shown in this study, is that it can cause dramatic redistribution of perfusion inside the lung after injury. And this is a canine model of oleic acid injury installation. And you can see at the beginning, before injury, we see the distribution of perfusion by positron emission tomography. And we can see a fairly homogeneous distribution of perfusion. Right after induction of the lesion, of infusion of oleic acid, we have this dramatic redistribution and look at the dependent parts of the lung. They're completely absent, at least with this method of detection, of perfusion. As you can see also here, the dramatic reduction in the fraction of pulmonary blood flow after injury in the most dependent dorsal parts of the lung. Interestingly, this area also is the one that is probably submitted to the highest ventilatory stress. So in this model, in the dependent part of the lung, we will have a lot of flooding, edema, and collapse of the lung. But this area here is the area submitted to tidal recruitment, to expansion or cyclic expansion of the lung. So here we're adding two mechanisms of lesion. One, the excessive perfusion caused by an excessive hypoxic pulmonary vasoconstriction, and the second one, the ventilation. That is being very heterogeneous in that region of the lung. Also interestingly, in the same model, if the animals were given endotoxin previous to induction of the lesion, we could see that this distribution was completely abolished. The hypoxic pulmonary vasoconstriction reflex was abolished, and you can see that the result was still a very homogeneous distribution of of perfusion, but a significant reduction in PO2 because of the VQ mismatch. That was not the case when the blood flow was redistributed. So, the path that the pulmonary circulation follows from the right chambers to the left chambers can be divided in three segments. We have mainly been until now talking about the upstream segment or the arterial part. But the interesting part where many of the problems arise during mechanic ventilation in ARDS is the intermediate segment. That is where the capillary and the alveolar structures are. So in this intermediate segment, there are different types of vessels according to the to the biological function and to their location. Vessels that are surrounded by different pressure challenges. We have the alveolar vessels that are close to the alveolar walls and submitted to changes mainly in the alveolar space. And we have the extraalveolar vessels that are in the interstitium between the different alveoli. The important thing is that both vessels have a different behavior during lung inflation. During lung inflation with normal volumes, the alveolar capillaries are compressed, so because the alveolar pressure is increased, so the transmural pressure is kept constant, or at least does not increase. Whereas due to the interdependence of the alveoli, the expansion of the lung creates a negative interstitial pressure, and this is causing an increase in transmural pressure that at the beginning increases the diameter of the vessel, elongates the vessel, and if the stress or the inflation is of a certain entity, it can end up causing capillary stress fracture even in the extraalveolar vessels. And this is what happens in normal lungs. When we have a heterogeneous ARDS lung, all these mechanisms are amplified. So in the stress distribution model of Mead, he calculated that the stress induced by tidal inflation is greatly amplified in the interface of collapsed alveoli that are surrounded by inflated alveoli. So the effective pressure, that is the pressure that is created around this interface, is greatly amplified and equals the applied pressure to the expanding alveoli multiplied by the final volume that is theoretically reached by this inflation pressure, divided by the initial volume and raised to the 2/3 power. Playing a little bit with numbers and assuming that a normal alveoli can amend 10 times its volume, this means that with a pressure of 30 centimeters of water, we can create local pressures around the alveoli of about 140 centimeters of water. This puts us again close to the pressures that were causing the capillary stress failure only by increased hydrostatic pressure in the models I presented at the beginning. So these pressures do actually exist in the lungs of patients with ARDS. So the risk of presenting capillary stress failure is high, and actually occurs. And the expression of that is the appearance of hemorrhage and lesions in the dependent portion of the lung, where the expression of these phenomenon, of these amplifications of stresses, are maximum. So a number of studies have been trying to elucidate the different effects of altering the different elements that are causing this stress. On one hand, these investigators wanted to look at the effect of lung overinflation, and if it was able to only by inflating the lung, creating a stress failure. So in these animals, and in vivo rabbit lung, the animals were inflated with 2 different volumes at 2 different constant capillary transmural pressures. And they found that whenever they applied the higher inflation volumes, they had a increased number of capillary and alveolar breaks in the histology. And this effect was magnified when the transmural pressure of the capillary was also higher. Another important question to answer is it the flow or is it the pressure that is causing the capillary stress failure? And in this other study, they wanted to answer this question. What they did was they manipulated the flow and submitted ex vivo rabbit lungs to different flows, one below the normal flow and one above the normal flow, while maintaining the same static inflation pressures. The result was that the animals submitted to higher flow had a major decrease in compliance, a major increase in the ultrafiltration coefficient, and had higher pulmonary arterial pressure values. On the other hand, again, animals submitted to high flows had a increased number of perivascular hemorrhage in the extraviral vessels and increased number of red blood cells inside the alveoli, a clear indication that capillary stress failure was associated with increasing volume. What was the bottom line? The message of this study is that maybe reduction in cardiac output, that is the flow going through the lung, could exert a protective effect for the lung in terms of protecting it from ventilation-induced lung injury. Also, the frequency of the stress application is an important factor. And in this study, they also were able to show that applying the same pressure but at a higher frequency also caused an increased number of capillary stress failure, as shown by the increased hemorrhagic score that these animals had. Again, bottom line in this study was we should have caution with respiratory rate, especially when we are ventilating unevenly the lungs in a very heterogeneous lung. Then looking at the downstream side, that is the venous side of the pulmonary circulation, another important question was, do low vascular downstream pressures increase the potential for VILI? As if we increase the downstream pressures, are we increasing the likelihood of creating a ventilation-induced lung injury? This was studied again in an isolated rabbit lung model. And here animals were submitted to high inflation pressures, and one group was maintained with a normal left atrial pressure, and other group was submitted to a low left atrial pressure. And again, the animals with high inflation pressures but low downstream pressures had the major lesion measured by the change in a rate of edema formation and the change in permeability. Bottom line of this study, we should also be cautious with excessive negative balance when we're treating ARDS lungs. Another important aspect is the occurrence of atelectasis, and this is a increasing field of study of how, especially in the days of the NIH protocols that are recommended to all ventilated patients with ARDS, as you heard in the previous discussions yesterday. should we allow atelectasis to occur or not? Well, in this study where they actually measured what happens to rats, healthy rats, without inducing any lesion, they separated it in two groups. One allowed to collapse, and after 150 minutes, they had a tremendous incidence of severe right ventricular failure that was immediately reversed when the rats were recruited. So collapse tended to worsen the hemodynamic situation of these animals, causing this severe right ventricular failure. There also was a histologic deterioration in the endothelium. So the rats that were not recruited, that were allowed to maintain collapse, showed a thickened endothelial cell walls, and this happened in 40 to 50% of all cells examined on histology. So something is occurring in the atelectatic region that is causing vascular problems. We have seen it in our study in the saline lavage model, in which from a baseline situation with a huge amount of collapse and a PEEP level of 6, animals were recruited and then a optimum level of PEEP was set. Notice the difference between the PEEP level and the difference, although very small, but in pulmonary vascular resistance and in pulmonary pressure. So a recruited lung has a more homogeneous distribution of perfusion and ventilation, and is causing also beneficial effects in terms of oxygenation, inhibiting the pulmonary vascular, hypoxic pulmonary vascular response. So recruitment is improving the hemodynamic situation of these animals. Again, difference between recruitment or not, both isolated lungs ventilated with the same settings, same level of PEEP. One lung, this over here, was not recruited, maintained on this portion of the pressure-volume relationship in the inflation limb, and this other lung was previously recruited and then maintained on the deflation limb. So what are the potential implications for management? From the mechanical ventilation point of view, it seems logical to diminish the distending pressures and tidal volumes to avoid mechanical stress. Also, I would recommend to judiciously use lung recruitment and PEEP titration. Why? Because we can assume that we have a lot of benefits of this strategy. It redirects and homogenizes blood flow inside the lung. It diminishes the hypoxic pulmonary vasoconstriction. It reduces pulmonary vascular resistance. It reduces cardiac output. And it preserves surfactant function and synthesis. And it is important to diminish respiratory rate and ventilation, especially when we are ventilating heterogeneous lungs, because by this we can reduce the number of stress cycles imposed to the lung. From the hemodynamic point of view, it may be wise to try to reduce the cardiac output demands. This would cause a reduction in vascular pressure, the vascular pressure gradient across the lung. Then we should re-ask again if it's necessary to supra-optimize the oxygen transport to the other tissues, because this might be deleterious for the lung. We should also avoid excessive reduction in left atrial pressure by negative balance, because this increases the risk of VILI. And we should be cautious with local systemic vasodilators, because they have no proven benefit and may be harmful for the lung. So in conclusion, pulmonary circulation interacts with tidal ventilation, having an important role in modulating lung injury and ventilation-induced lung injury. Then lung pathology, mechanical ventilation, and the pulmonary vascular status have to be considered to establish the appropriate ventilatory strategy. Thank you very much.